right? My theory is that those who are producing a lot of forces, I mean, yes, they have their AOB, but unless they're actually at nighttime, if they're a 17.5-minute chewer and their teeth are touching, 17.5 minutes a day, then they're with not much force, then, the teeth aren't taking that much force. But nocturnally, during parafunction, we can produce 4 times as many forces as we can when we're aware of it. So if you tally up the fact that we have a parafunctional patient with an AOB versus a less parafunctional patient or non-parafunctional, which are rare nowadays, with an AOB, then that may have one role. The other theory that I subscribe to is that there's perhaps a weak point. So if we look at their teeth, if we look at their periodontium, and if we look at their TMJ, for example, then one of these, they naturally have potentially a weak point, and whichever is the weakest link will suffer. So for example, if the biotype of their periodontium is hard, and you know what I mean, the type that have got exostoses that are never going to get perio because they've got surplus of bone, even they smoke 50 a day, they don't brush, but they don't have any perio because they're almost genetically immune in a way to perio, right? So they got really fantastic periodontium, but then they're getting cracked teeth because the parafunction is actually overloading the teeth, but not overloading the threshold of perio. That's a theory. What do you think about that? I
think you hit the nail on the head when you said genetic. We know whatever health survey you look at, whether it be the Adult Dental Health Survey, the NHANES in North America, if you look at the initial studies on periodontitis in populations in Sri Lanka, it's all the same. 50% of people have periodontitis, 10% have severe periodontitis. They're roundabout. It's pretty much the same wherever you go. Now, so even in untreated populations, treated populations, Western civilization, third world, it's all the same, which means there's a massive genetic part to play. Yes, there are risk factors. You've got the smoking risk factor. You've got diabetes as a risk factor, which have strong links to periodontitis, but it's all to do with susceptibility. And this is what I tell patients all the time. I'll say that if I've diagnosed them with periodontitis, with severe periodontitis, I say, unfortunately, you are highly susceptible to something called periodontitis. Okay. Whilst 90% of people, as you said, could brush to their heart's content or could not brush to their heart's content and not have perio disease, okay, the 10%, if they just look at plaque for a second, they've got periodontal disease. So I think shifting the blame away from you're not brushing your teeth to you're susceptible to it, so you really need to. It's a difference, and patients respond a lot better to it because they are empowered by the fact that they know that they have something which is which they are susceptible to and that can be managed. And I think I think I've gone off on a massive tangent.
No, I think what you said was great.
Coming back to the tangent, why do some people with OABs don't have that bone loss? Because 90% of individuals aren't susceptible to severe periodontal disease. If they are in that 10%, they're going to get it. And
do you find that your patients with AOBs, now this is an interesting question because I just thought of it now, it wasn't scripted or anything. So those patients with AOBs that are susceptible to perio, are they also having the same bone defects around their anterior teeth?
It depends. There are lots of factors. So if they are smokers, they'll get defects anteriorly. Because by virtue of where they hold the cigarette, you get a local vasoconstriction, as opposed, and a general as well, but more localized at the front. But or if they're mouth breathers and it's hard to brush, you get greater inflammation anterior. So there's lots of factors, but it's often I'll see posterior bony defects around patients with anterior open bites.